Hi, how are you? Okay, I think we need to start the session because of time. So in the previous lesson, we have discussed about acute rheumatic disease and rheumatic fever. So today I'm going to take you through about stroke. And if you remember, we have mentioned something about stroke in the previous class, and we have talked about the classification. So generally, a stroke can be classified into two broad categories: the ischemic one and the hemorrhagic one. But the ischemic stroke ones are the most well known, which accounts for 87% of the cases. So ischemic stroke, normally you can actually even say like 20% of ischemic stroke is due to atherosclerosis, cerebrovascular disease, and like 20% can be due to cardiogenic emboli, and 30% of the cause of ischemic stroke is cryptogenic. That means the real cause is not really known. So this ischemic stroke can be due to either local embolus or thrombus formation that can cause occlusion of the cerebral arteries. This is the major mechanism. So ischemic stroke is either due to local thrombus formation or emboli. So you can actually even see how ischemic stroke look like after occlusion of the cerebral artery. So this is normally the area of necrosis due to, or this is the area of ischemia whereby there is deprived of oxygen and nutrients because of occlusion. Then ischemic stroke is similar to transient ischemic attack, but the major difference is in ischemic stroke, you'll see tissue necrosis as well as infarction. Sorry, you will see tissue necrosis and infarction in transient ischemic attack, in ischemic stroke, but there is no residual deficit and infarction in cases of transient ischemic attack. That is the main difference between the two. And TAIs are a risk factor for acute ischemic stroke, and about 15% of the case of ischemic stroke is having a history of preceding transient ischemic attack. So when you say hemorrhagic stroke, it is actually due to bleeding into the brain as well as the central nervous system, and it can be subarachnoid hemorrhage, intracerebral hemorrhage, as well as subdural hematoma, and you will see it later. And generally, hemorrhagic stroke is very lethal. It's more lethal than ischemic stroke, and it is mostly associated with uncontrolled high blood pressure, as well as antithrombotic or thrombolytic therapies. So this is how the hemorrhagic stroke look like. You can actually even see the bleeding outside the blood vessel, which actually leaks to the brain and the CNS parts. So hemorrhagic stroke, as I mentioned before, there are different types of hemorrhagic stroke. The subarachnoid hemorrhage, this is the space between the inner and the middle layers of the meninges. Remember about the meningeal layers are known as DAPA. So D stands for dura, arachnoid, and pia mater. So like there is a skull. So this is skull. Then after that you'll get the meninges. The first layers of the meninges you can get is the dura mater, then arachnoid, pia mater. After that, you will get the brain parenchyma. So in the case of subarachnoid hemorrhage, the bleeding is usually between the inner part, that is the pia mater, and the middle layer, that is arachnoid area. We call it subarachnoid space. So if there is a bleeding in this area, we call it subarachnoid hemorrhage, and mostly it is due to a trauma or rupture of several aneurysm. Those are small and weak blood vessels. They do have high tendency to rupture in case of trauma or any high blood pressure. Then intracerebral hemorrhage is actually like a bleeding inside the brain parenchyma. So it is just bleeding directly to the brain parenchyma, and is mostly due to uncontrolled hypertension. So this one is how the ECG, the CT scan look like in case of intracerebral hemorrhage. So you can actually even see, in case of, by the way, if there is a bleeding in the meninges, you will see actually a whitish spot somewhere here, like at the side of the meninges. So this is known as like a hyperdensity or hyperintensity CT scan. So if you see this kind of spot, whitish spot, this is normally indicators of active bleeding. When you say a subdural hematoma, it is actually bleeding under the dura mater that covers the brain, and mostly it is associated with a trauma. So I don't know whether you can see the CT scan result of a patient. So can you see normally this like these dark areas, or like these hyper intense areas? Like these hyper intense areas are, this is the site of the hemorrhage on the CT scan. So this is an indicator there is there is actually a bleeding in the subdural hematoma from the CT scan result. Mostly it is just because of head trauma. That is the main causes of hematoma or bleeding in the subdural space. So when you look at hemorrhagic stroke, what causes or what is the mechanism of toxicity of hemorrhagic stroke? Mostly, hemorrhagic stroke effect is due to the massive and the neurotoxicity effect of blood components and their degradation products. Remember, when there is a bleeding, blood by itself is neurotoxic, and it can cause destruction of the neuron. And apart from that, because of the hematoma formation in the tissue, it can cause localized compression. So this is normally the mechanism of neuronal damage due to a hemorrhagic stroke. So let's see about the pathogenesis of ischemic stroke. In case of ischemic stroke, there is an interruption in the blood supply through an area of the brain. We call it thrombus formation or an embolism. So when there is an embolus or a thrombus, they're responsible to interrupt the blood supply. So this ultimately causes what? This actually loses cerebral blood flow, ultimately results in tissue hypoperfusion and tissue hypoxia, and ultimately this can occur. But however, the principal mechanism of thrombus formation in the brain cells is started because of lipid deposition in the blood vessels. Remember what we have covered in venous thromboembolism is, and in coronary heart disease, is actually is describing the mechanism of ischemic stroke. So when there is a lipid deposition, it can actually aggravate the risk of clot formation and ultimately causes blockade. And apart from that, when there is actually an injury, maybe because of high blood pressure, what will happen? There is exposure of the innermost layer of the endothelium, known as the subendothelial layer. So this subendothelial layer can actually is a potential environment for platelet aggregation. So the platelet will actually aggregate together, and it causes even clot formation. And apart from that, when there is actually injury in the vascular environment, it can activate the coagulation cascade, what we have seen in the previous session, and leads to thrombin formation. So this thrombin will be converted to, is responsible to convert fibrinogen to fibrin and leads to ultimately for clot formation. So this is the principal mechanism of clot formation in cases of ischemic stroke. But remember, the emboli can occur from cardiogenic system because of atrial fibrillation or maybe valvular disease, what we have seen in the previous lesson. And it could be even stenosis of the carotid artery, which is the main arteries that supply blood to the brain, or it could be even a plug in the carotid plug. We call it arteriogenic emboli. So those are the possible mechanism which is responsible for the occurrence of what? The occurrence of ischemic stroke. So in short, after the event, after like the after the blockage of blood flow to some part of the brain, what will happen? There is activation of excitatory amino acids. So this activation of excitatory amino acids can cause intracellular accumulation of calcium, and they can also activate inflammation, inflammatory reaction, and generation of free radicals. This ultimately causes death of the brain tissues. But remember, all those events are occur within a short period of time. Yeah, within the onset of 2 to 3 hours after the onset of ischemia, this ultimately causes the death of the brain tissues. But in case of hemorrhagic stroke, the pathophysiology not really known. It is not well studied like ischemic stroke, but what is known is when there is a blood in the brain parenchyma, brain can cause mechanical compression, and apart from that, blood can cause subsequent activation of inflammatory reaction in neurotoxin because of their damage effect. So this is all about the pathogenesis of this condition. Then, what are the clinical features of stroke? Let us see the clinical features of ischemic stroke. Okay. So in most of the cases, the patient may not able to give you reliable information because of cognitive and language deficit. So most of the time, in case of stroke, we're relying on secondary information from the caregiver or from the family members or from any other witnesses during the attack. So that is the source of information. But most of the time, the patient may experience weakness on one side of the body, and inability to speak, a loss of vision, vertigo, like spinning sensation. So they are feeling something is actually spinning on their head. We call it vertigo. And ultimately, there is a possibility of falling. So this is a very common manifestation in majority of stroke patients. Stroke patients, such as ischemic stroke, is not commonly painful, but headache can occur. But most of the time, headache is very severe in cases of hemorrhagic stroke. Okay, so you can actually even see the effect on the brain is mainly inability to speak properly and confusion, like they are not oriented impulsively. Then they might have bad headache and they can even lose their balance. So in the eye, they do have actually a problem in the vision. On the face, they do have an ability to maintain like their balance, and numbness and weakness is very common, and mostly on one side of the body. And they're feeling tired and they are not able to work properly. Those are the major manifestations of ischemic stroke. But what are the signs and symptoms of hemorrhagic stroke? There is a sudden and severe headache, nausea and vomiting can happen, and also the patient can have photophobia. Those are very, very common manifestation when a patient is having hemorrhagic stroke. But most importantly, the headache is very high. So most of the patients are complaining. They're complaining like they're experiencing the worst type of headache in their life. Yeah, so headache is very severe in cases of hemorrhagic stroke. Neck pain and local rigidity may also be experienced at the time of hemorrhage. Those are some of the complaints. Then, how do we diagnose? What are the most common diagnostic modalities for stroke? So far, there is no specific lab test for a stroke, but there is a test for hypercoagulable status. Maybe if the cause of the stroke is not determined, you need to do hypercoagulable tests like protein C, protein A, antithrombotic level, and of course, antiphospholipid antibodies can also be determined. So those are the tests that can be considered, but most of the time, CT scan of the head is the most important imaging in our setting. So most of the time in our setting, if a patient is having clinical impression of ischemic stroke or any stroke, they are supposed to do CT scan to rule out whether the patient is having hemorrhagic stroke or ischemic stroke. So the area of hyperintensity that is wide is an indicator of a hemorrhage. So there is an active bleeding, as you have seen in the previous slides. Then the CT scan will either hypointense dark area is mostly indication of ischemia or infarction. Then the major problem with CT scan is usually sometimes it will take 24 hours to reveal the area of the infarction. That is why MRIs are commonly recommended because like before 24 hours, you can actually even see the area of ischemia and it has a better resolution. So this time around, unless the cost issue, MRI of the head is recommended even in the diagnosis of stroke. But mostly because of cost issues, most patients undergo CT scan. Then maybe we can do carotid Doppler studies can be done. This is normally to determine whether there is stenosis of the carotid arteries. Then maybe ECG can be done. This will help us to determine whether the patient is having atrial fibrillation or not. Or also we can do echocardiogram to see any valvular abnormalities in the heart that affect the formation of blood flow to the different organ and ultimately causes clot formation. So those are the most common tests, but mostly CT scan or MRI is the most common test that should be done before treatment. So let's see about the general principle of treatment. So the general approach for treatment is make sure you have CT or MRI scan to differentiate whether the patient is having ischemic or hemorrhagic stroke. That is very essential because the treatment is different. Then, if a patient is having ischemic stroke, need to evaluate whether the patient is eligible to take the perfusion therapy or not. If a patient is having hemorrhagic stroke, assess whether there is an evaluation, like surgical evaluation assessment should be done so that whether the patient can do surgery to clip the aneurysm or to remove the clot inside the brain. So those are the general approaches we need to consider before treating stroke. So let us see treatment of ischemic stroke first. So based on your previous understanding, how do we treat ischemic stroke? How do we treat ischemic stroke?
Can we use vasodilators?
Which vasodilators?
Maybe, I don't know, calcium channel blockers or things like nitroprusside, and I don't know.
Okay. Okay, good observation. But they are not approved normally for treatment. I really normally like it the way you think about the management of ischemic stroke. But we do have better strategies to treat this condition. That is why we are not going to use this class of drugs unless to control high blood pressure. Okay, good. So what is the short-term goals of therapy of ischemic stroke? The first goal is we need to reduce secondary brain damage by reestablishing and maintaining adequate perfusion. That is very important. We call it neuroprotection. The long-term management is usually preventing recurrent stroke through reduction and modification of risk factor. So the first goal is maintaining reperfusion or restoring reperfusion. Then the second long-term management is just prevention of recurrent attack of stroke. Then cardiac monitoring should be continued for the first 24 hours to screen whether the patient is having atrial fibrillation or not. Then look at the oxygen saturation. Otherwise, if oxygen saturation is less than 94%, they are supposed to provide oxygen administration should be done. Then, of course, a volume status and electrolyte imbalance should be corrected initially. Then after that, we need to even check the blood glucose level because both hyperglycemia and hypoglycemia can worsen ischemia. Because of this reason, we need to correct the blood sugar level accordingly. If the sugar level is very low, maybe we need to give bolus administration of dextrose. If the sugar level is very high, we need to give subcutaneous insulin administration should be given in cases of hyperglycemia. If a patient is in case febrile, give acetaminophen because fever can actually increase brain ischemia. So those are the most common supportive measures that can be considered. Then, most importantly, there is a scenario whereby in acute setting, about 75% of the patient have an elevated blood pressure in the first 24 to 48 hours. So this is the major problem in a stroke patient. So in generally, BP should be optimized if the blood pressure is very, very high. However, in general principle, high blood pressure should not be treated in acute period, especially in the first 12 to 24 hours. Why? Because if we give antihypertensive medication, it can reduce the blood flow to the ischemic areas and it can worsen the condition. So in general, if the blood pressure is not excessively elevated, such as in cases of hypertensive crisis, we are not supposed to treat or we are not supposed to use antihypertensive agents in the first 12 to 24 hours in cases of ischemic stroke because of the reason I mentioned. Then, even the American Stroke Association guideline recommends blood pressure should not be treated unless they are actually above 220 to 120 millimeter mercury or any other evidence of maybe any other condition that leads to treatment, acute MI, pulmonary embolism, hypertensive encephalopathy. Unless the patient is above this BP, according to this guideline, it is not recommended to initiate treatment within the first 12 to 24 hours. In case if the BP is above this level, maybe we can use antihypertensive medication to reduce the blood pressure, and mostly vitalol or shock-acting parenteral antihypertensive agents should be recommended. Then, what is the recommendation, especially for ischemic stroke? If a patient is supposed to give alteplase, that is acute treatment for that is acute treatment for ischemic stroke. Like if the patient is actually having a high BP before treatment, make sure we need to give a Bitalol at least 10 to 20 milligram IV. Then we can repeat in 10 minutes if there is no improvement. After that, maybe we can initiate the treatment. Yeah. Then, if a patient is not eligible to take alteplase, there is no need of actually treating BP if there is no end organ damage with a BP of systolic less than 220 and diastolic of less than 120 millimeter mercury. But however, if it is above, the probability of clot formation or hemorrhagic stroke is very high, so we need to control the BP. Yeah, otherwise, the high blood pressure can cause even another stroke. Because of this reason, we need to give Labetalol. Yeah, that can be repeated until the maximum of 300 milligram infusion. Okay, so those are the recommendations. Then, according to the American Heart Association or Stroke Association, what are the acute treatment modalities for ischemic stroke? So, if a patient is admitted within 3 hours with onset of symptoms of a stroke, IV tissue plasminogen activator, only alteplase is approved in the acute setting of ischemic stroke. Alteplase can be given, but not that the patient should be admitted within 3 hours of the onset. That is whereby we can obtain maximum effect of thrombolytic effect of alteplase. Otherwise, if a patient is actually admitting to the hospital like 3 hours after the onset of the condition, the use of alteplase outweighs the risk. There is no benefit, but it can increase the risk. Tiffany?
Sir, is ischemic stroke mainly just caused by a clot that is blocking the carotid arteries? Or it can also be due to atherosclerosis?
It can also be due to atherosclerosis, huh? Yeah,
Yes.
but have you mentioned, do you remember about what we said about the causes, huh? The causes of ischemic stroke at the beginning, yeah? Let me show you, like, okay, this one, yeah, like 20% of ischemic stroke is caused by atherosclerosis, but like other 5% of the causes are actually caused by prothrombic events, and 20% are caused by cardiogenic emboli, but around 30% of the cause of ischemic stroke is not known. So majority of the causes are not known, but 20% is due to cardiogenic and 20% is actually due to atherosclerosis, and 25% is actually due to penetrating artery disease. Those are actually thrombus formation into the deep arteries of the brain. Yes. So those are okay, good. So when you look at the treatment, we need to watch out about like the use of alteplases should be only within 3 hours onset. Otherwise, they can even the evidence says it can localize the clot. City?
Sir, when you say that 5% is the cryptogenic, that means the cause is unknown, right? How do you treat that one? Because that means you've done all the tests and seen that it's not a clot and it's not a thrombi, it's not atherosclerosis. So how will you treat that patient?
By the unknown means by the there is no known causes what causes the clot. Otherwise, there is a clot. Huh? Remember, there is a clot, but we don't know what causes that clot.
Okay.
Did you get it? Huh?
Yes.
Yeah, otherwise we can't say even ischemic stroke. Huh? When we say ischemia, it is just like blockage due to clot formation. It could be a thrombus or embolus. What is the difference? Maybe City. What is the difference between thrombus and embolus?
Thrombus, it's a clot like a blood clot, and emboli is like a gas bubble, for example.
Okay. Okay. You are actually thinking about there is air embolism, of course, there is fat embolism, and there is also a clot. But anyways, when you say clot, when we say thrombus, it is actually locally produced. It is produced and it causes blockage at the site of formation. But when you say embolus, it is a clot that can move. So that means when you say embolus, it is actually produced elsewhere, but when the patient is actually maybe moving, then the clot can actually dislodge it, then it goes to the circulation and ultimately goes to the brain and causes blockage. That is why, if you remember, in acute treatment of DVT, the moment you are actually, the moment the patient is having DVT, bed rest is usually recommended for a few days to prevent dislodging of the clot. If they exercise during acute episode, the clot can actually dislodge it and it goes to the brain and even to the lung, causes pulmonary embolism. Yeah, that is why bed rest is commonly recommended in acute phases of even deep vein thrombosis. Okay, good. So embolus is a clot that can move. Then tissue plasminogen activators are the one that is can be used in a setting. But if a patient is admitting in the hospital 3 hours later, aspirin is the only antiplatelet agent that is approved for the use in acute treatment of ischemic stroke. So remember, even this time round, getting alteplase is not very easy, by the end, very expensive. Huh? Because of cost issues, I've never seen a patient who has been on alteplase treatment. And apart from that, most physicians, they fear the risk of transformation to hemorrhagic stroke. The problem with this class of drugs is the possibility of transformation is very high. It can actually cause. I just normally hear like a case study, like the patient was completely actually resolved from the attack after the use of alteplase. Otherwise, I've never seen this. I don't think so. You can even get the chance to see the drugs because it is not commonly used in our setting. So the most commonly used drug in our setting is aspirin. That one we'll talk in detail more. Then I have already mentioned if it is not initiated within 3 hours, it cannot dissolve the clot. Rather, it increases risk of bleeding. Then CT scan should be done. That is very important to rule out. Remember, the treatment is totally different. That is why without having the CT scan result, you are not allowed to initiate any treatment for stroke patients. Yeah, you need to do. Yeah, but sometimes by the way, if you don't have. Okay, Tiffany?
Why is it that the alteplase can only work within a 3-hour window? Is there a particular mechanism, or it's just
It says
like that?
if the clot is actually like, it will work when the clot is fresh, but if there is actually strong, like 3 hours later means like after the clot is actually forming a strong fiber, alteplase cannot cause lysis of the clot. That is why it is not commonly included. So based on even the evidence-based trials, they said they have not gotten any benefit with the use of alteplase, and the patient is not like the perfusion of the patient is not restored even after the use of 3 hours. That is why they just normally stick to 3 hours, and some literature says by the after 4.5 hours. But this is where alteplase is actually effectively working to dissolve the clot. But after that hours, after the clot is aged, alteplase cannot dissolve the clot.
And why is it that alteplase is the only one that can be used out of all the other tissue plasminogen activators?
Remember, alteplase is like very fibrin specific. So based on evidence, remember, when I was talking, like this one is preferred is actually based on the guideline recommendation. So this is the only approved drug, and it is fibrin specific. Remember, fibrin specific drugs are very effective. So according to the FDA, they find out the promising effect with Altiplase is actually by far better with a minimum risk of bleeding as compared to the other tissue plasminogen activator. That is why it is only FDA approved drug for treatment of acute ischemic stroke.
Okay, thank you.
Okay, so if you're interested, you can read more, but I usually give much emphasis like for the drugs which is commonly available, yes. So, okay, good. And now, maybe because we might have a chance to see, to get the drugs, depending on the facility, the doses are 0.9 milligram per kg. The maximum dose we can administer for Altiplase is 90 milligram. Whatever the kg of the patient, like if the patient is above 100 kg, the maximum we can give is 90 milligram because of the risk of bleeding. So what you can do is calculate the dose of the patient, the dose of the drug based on the weight of the patient. Then after that, like the first 10% of the total dose will be given in the form of bolus, then the remaining dose will be given in the form of infusion for the span of 1 hour. So this is how we are going to administer. So combination of infusion and bolus is usually given, but 10% of the total dose is usually given in the form of bolus. Then this is in case when we are initiating Altiplases. When we are initiating Altiplases, we need to look at whether the patient is eligible to take Altiplase or not. So far, according to the FDA, it is only approved by them for a patient older than 18 years. But even in some facilities, normally even like based on like previous studies I have seen, the use of even Altiplases in children if they do have a stroke. Maybe children sometimes get stroke if they do have other comorbidities such as sickle cell anemia. Then make sure the patient should have a clear diagnosis of ischemic stroke. That is very important. Otherwise, we can kill the patient. Then the onset of the symptom should be less than 180 minutes, that is 3 hours. So beyond that, the effect is very minimal. It says even some old literature says it has actually almost no effect if the clot is above 3 hours. Then those are the inclusion criteria. Then exclusion criteria, evidence of intracranial hemorrhage. If a patient is having evidence of any bleeding, we're not supposed to use. Then highly suspicious of subarachnoid hemorrhage, mostly subarachnoid hemorrhage, even with normal CT scan, yeah, there is a possibility based on the clinical parameter. Then active internal bleeding. Okay? If a patient is having active internal bleeding, we are not supposed to use. I think you can actually go through all the parameters when you get time because the information is self-explanatory. Then the systolic blood pressure should be above 185 or the diastolic should be below 180 millimeter mercury. But if it is above this, we are not supposed to use because risk of bleeding is very high. Remember, if the BP is very high and if you give Altiplase means that actually even the risk of bleeding is very high in case if the blood vessel rupture. That is why for high BP patients, we are not allowed to use Altiplases. Let's see about antiplatelets and the use of anticoagulants in cases of stroke management. As I said before, from antiplatelet agents, the only approved drug is aspirin for acute management. It is very effective antiplatelet agents. That is why it is commonly recommended for acute management. So, in general, if a patient has taken Altiplase in the first 24 hours, we are not supposed to use any other anticoagulants or antiplatelet agents because of what? bleeding risk. So once you have given them 24 hours later, you give them loading dose of aspirin. That is 160 to 325, but mostly in our setting, they usually use 300 milligram aspirin. I think that is the one which is available. You give them loading dose of 300, then after that, 24 hours later, you give them 75 milligram because of the risk of bleeding. So like after you give them acute reperfusion therapy of alteplase, 24 hours later, you have to initiate aspirin. So guideline recommends, by the way, it says it has been shown to reduce long-term days and disability. That is why aspirin is commonly recommended. But mostly alteplases we usually use start dose, like infusion for 1 hour, that is all. Then antiplatelet therapy is the cornerstone for secondary prevention of ischemic stroke, and they should be used only in non-cardio cardioembolic strokes. So according to a comparative study which was done in many patient population between the use of anticoagulants and antiplatelets in non-cardiogenic emboli, they find out there is no superiority of anticoagulants in terms of prevention of ischemic stroke in secondary prevention as compared to antiplatelet agents. Because of this reason, the guideline, the American Stroke Association usually recommends use aspirin or any other antiplatelet agents as a secondary prevention if the emboli is not cardiogenic emboli. But if the emboli is cardiogenic emboli, anticoagulants are more effective. Titi?
For alteplase,
Mm-hmm.
the inclusion criteria is that the patient is above 18. So what if
Yeah,
the patient is below 18? What will you do in such a case?
that means there is no there is no much studies about in pediatric population. That is why I said, but based on practice, in some countries, normally they use like few studies normally shows even the use of alteplase in children, but generally it is approved only for adults, not in children, because there is no much studies in pediatric population. And apart from that, the stroke is not very common in pediatric population. By the way, it is very unlikely unless the patient is having hypercoagulable status because of genetic deficiencies. There is no much studies in pediatric population. That is why it is commonly improved for adults.
Okay.
Okay, good. Then please note of the use of antiplatelets only non-cardiogenic emboli, but if the emboli is due to cardiogenic factors, maybe due to valvular problem, due to heart failure, due to atrial fibrillation, anticoagulants are superior in terms of outcome as compared to antiplatelets despite the bleeding risk. But in non-cardiogenic strokes, antiplatelets can equivalently prevent a risk of recurrent ischemic attack without having risk of bleeding. That is why antiplatelet agents are commonly recommended. Okay, then secondary prevention, as I mentioned before, we can use aspirin and clopidogrel, but I have never seen the other classes of antiplatelet medication by the dipyridamole. I've never seen, but anyways, in our setting, you'll get clopidogrel and aspirin. Both of them are 75 milligram and 300 milligram. Then this combination is commonly used, and apart from that, the combination of aspirin and clopidogrel is not very common unless the patient is having ischemic stroke with recent history of MI, or if a patient has done any stent placement. In that scenario, he can use aspirin with clopidogrel. Otherwise, the risk of bleeding is very high. So mostly we use it like alone. Then in secondary prevention with atrial fibrillation or any other cardiogenic emboli, we have to use oral anticoagulants, and warfarin is the most commonly used agent as secondary prevention. Then also the newer anticoagulants, by the way, despite the cost, they can also be recommended. Especially, they do have better advantage over warfarin, because for newer agents, by the way, there is no antidote. There is no even like there is no need of frequent monitoring. So rivaroxaban is locally available, but I'm not very sure about the other drugs. You just count, you check normally the essential drug list of Kenya, so that you can check whether the drug is available or not. Okay, those are the secondary prevention. So antiplatelets of stroke anticoagulants can be considered as secondary prevention, because the recurrence is very common in majority of the patients after the first episode. The next thing is blood pressure control. Remember at the beginning, as I said, the most common causes of hemorrhagic stroke is uncontrolled blood pressure. But also high blood pressure can cause also ischemic stroke. So and it is very common, blood pressure is elevated after ischemic stroke, and it is commonly associated with increased risk of recurrence. So because of that reason, adequate BP control is very essential as part of secondary mechanism, because with treatment, it decreases the degree of recurrence. Then what is recommended? According to the JNC guideline, as well as the American Stroke Association, ACE inhibitor with diuretics are commonly recommended at the blood pressure control in stroke patients. But of course, if a patient is not tolerating ACE, we can use ARBs can be considered. Then, apart from that, ischemic stroke is equivalent to coronary risk. That means there is a need of the use of statins. Yeah, there is a need of actually the use of statins. This is anti-hyperlipidemic agents until we achieve LDL is less than 100 milligram per deciliter. But sometimes there is a need to use low molecular weight heparin as well as low dose of unfortunated heparin in the form of prophylaxis. But remember, another point to note, low dose of low molecular weight heparin, subcutaneous heparins are not approved in acute treatment of stroke. So based on the studies, they have said there is no much benefit, and there is actually a lot of inconsistencies in the result. Because of that reason, it is not approved. That is why the guidelines approved the safety and efficacy of aspirin and alteplase in acute setting. So in summary, those are the recommended pharmacotherapies in ischemic stroke. In acute attack, look at whether the patient is eligible for tissue plasminogen activator and give the alteplase. If a patient is not eligible, maybe you have to give loading dose of aspirin, that is 300 milligram. Then after that, you continue to give 75 milligram 24 hours later. Then secondary prevention, look at whether the patient was having cardiogenic emboli or cardioemboli. If non-cardiogenic, consider antiplatelet agents like 75 milligram. Then if a patient is having cardiogenic emboli, you can use what? Warfarin. Warfarin can be used. Also rivaroxaban can also be used, 20 milligram daily. Then give statins. Then you can actually monitor the blood pressure. Medication, ACE inhibitors, and this diuretic can be considered. So this is how we are treating ischemic stroke. So maybe let me ask you a few questions, whether you captured the information. Okay, let me start from who? Alfred? Alfred, can you hear? Okay, good. Then Anna,
Yes.
so what's the difference between hemorrhagic and ischemic stroke?
What?
What is the difference between hemorrhagic and ischemic stroke?
Hemorrhagic is when there is bleeding in the brain,
Mhm.
while ischemic is caused by a blood clot
Okay,
or
good.
trauma.
Okay, good. So what is the mechanism of toxicity, like mechanism of neuronal damage in cases of hemorrhagic stroke before you leave?
It can reduce the amount of blood going to the kidneys.
Okay. Mechanism of brain damage. Yeah. What I said is,
Oh,
what is the
brain.
mechanism of brain damage? Huh?
Because there is leakage of blood from the vessels,
Uh-huh.
it will cause tissue damage on the brain cells.
Yes, it is just direct toxicity of the metabolic product of the blood cells and the blood component by itself, or also local compression. Okay, good. Thank you. Now you can leave. Then Alan,
Yes.
why one side weakness of the body is very common in stroke patients?
Sorry, come again?
Why in the clinical presentation we said weakness or paralysis on one side of the body is the most common defining feature in stroke patients, and why this is so?
I'm not really sure.
Can you nominate some other person to assist you?
Maybe Tiffany can help.
Okay, Tiffany.
You're asking about in ischemic stroke, right?
So why in stroke normally, in general in stroke patient, why one side weakness on one side of the body is like the most common features?
Okay, so I'm trying.
Mm-hmm.
For example, let's say in ischemic stroke, we talked about blockage occurring on one branch of the carotid artery, bleeding. So each branch supplies one side of the brain, and therefore, if it's the left carotid artery that is blocked, then you'll have damage occurring on the right side of the brain, and therefore you'll have a problem with that side of the body, if that makes sense.
Exactly, yes. So remember, the motor innervation in the brain is normally contralateral. Like for example, if a patient is not able to move, means there is actually damage in the motor neuron. Yes, there is damage in the motor cortex that controls body movement. So that control is contralateral. That means the left side controls the right side, and the right side controls the left side. And mostly, like blockage of the whole part of the brain or both is very, very likely. So that is why when there is a blockage on the right side, that means the right part of the brain that control the motor areas is actually can cause damage. So there is actually like contralateral innervation in most of the time. That is why we are going to see like all weaknesses on one side of the body, starting from the upper extremities, the upper limbs, to the lower limbs. Okay, good, Tiffany. Still, you are actually the front line in the class. Then another question, Tanzil.
Yes, sir.
So how do we treat stroke? Chemical stroke, sorry.
So if it's within 3 hours of onset of the symptoms, give IV altiplase. Give a load 10% bolus over 1 minute, and then the rest over 1 hour. And then give aspirin 48 hours of onset of stroke.
Okay, good. Then continue secondary prevention. Okay, good. So I'm expecting by now you do have some information about the management of ischemic stroke. And as I said before, in our setting, like aspirin plus secondary preventions are the most common modalities of treatment. Okay, so this diagram, I think you can study on your own time. So this is the summary of what we have said. And also still, this one is also a brief summary. I just normally like it. That is why I just included it in the slide so you can read. Now, let me take you through about treatment of hemorrhagic stroke. Now here, there's bleeding. So this bleeding causes local compression. And apart from that, this bleeding can cause direct damage and also activates inflammatory reaction and causes neuronal death. And it is very severe and very lethal. And most of the time, if a patient is having hemorrhagic stroke, you don't really even see the warning signs of like weakness of the face, and then the weakness of the arms and the sweat. So most of the time, the patient is suddenly unconscious and fall down, which is very, very common. So what are the goals of therapy? The short-term goal is neurointensive care. So we maintain adequate oxygenation, breathing, and circulation. And the long-term goal is prevention of complication so that we can actually prevent recurrent bleeding and delayed cerebral ischemia, which is very important. Please note about delayed cerebral ischemia because one type of hemorrhagic stroke is very notorious to cause delayed cerebral ischemia, and I will come later. Then so far, there is no standard pharmacological strategies for treatment of intracerebral hemorrhage. So far, there is no like well-known treatment in the management of hemorrhagic stroke. So what are the guidelines suggest? So if there is hematoma that can be evacuated by surgery, like you remember after they clot, they can actually, after they bleed, they can form a local clot, which is known as hematoma. So if it is not within the brain parenchyma, most of the time they can be evacuated by surgery. So there is role of surgery. Then apart from that, if a patient is actually hypertensive, control the blood pressure. That is very important information to know. Then apart from that, if a patient is actually having a stroke, sometimes they can develop seizure. So remember, seizure is just sudden electrical fire in the brain. It is just like electric fire in the brain. It is just equivalent to fire, but it is just electrical activity in the brain. So that means when the brain excitatory neurotransmitters such as glutamate is overactivated, and when the inhibitory neurotransmitters like the glycine, the glutamate, glycine, GABA, those are GABA, when they are inhibited, overactivation of excitatory neurotransmitter is very common in cases of hemorrhagic stroke, so the patient can have seizure. So maybe anticonvulsant drugs can also be considered. Then apart from that, you need to consider temporary arrest of bleeding. So how do we arrest bleeding temporarily? Maybe clipping of the intracerebral aneurysm. Those are the role of the neurosurgeon. They can actually clip it so that they cannot bleed. Then the most common modalities in our setting is the use of tranexamic acid. Tranexamic acid. Yeah, so do you remember about the mechanism of action of tranexamic acid? Anyone who can recall? Tranexamic acid, TRANEXAMIC. then add acid. So is there anyone who can recall the mechanism of action of tranexamic acid?
I think it breaks down the fibrin mesh.
It causes what?
Breakdown of the fibrin mesh.
If it breaks down the fibrin mesh, will it help to arrest bleeding?
Yes.
How? How does it help?
Sorry, it doesn't arrest bleeding.
Yeah, it does not arrest.
It causes more bleeding.
It causes more bleeding, yeah?
Yeah.
Okay, good. So do you have any other opinion? Any other person? Thank you for your turn. Any other person? Faith? But where is Rodney today? Yeah, he's not in, and he has actually more than 7 absences. But they, like those two guys, you need to very watch out. Like Oliver and Rodney. If you are actually missing any other classes, like as of now, for sure, like your grade will be automatically F. Yeah. So like I have seen, like Rodney is not in today, and he joined normally in week 6. Why does it make sense normally? A pharmacy student who join normally at the middle of the semester. Yes. I think you're actually like, you two guys are actually like violating the policy of the university, so I can't tolerate beyond this point. Yes, if you miss any class, I just put your absences. Yeah, it's just up to you to decide whether to attend or whether to discontinue the session. Yes. Then any other person?
Does it block the degradation of the clot?
Yes,
increasing the half-life.
Yes, that is, you are actually in the right track. But the principal mechanism is, it is actually the opposite of, tissue plasminogen activator. Like the tissue plasminogen activator is important for the conversion of, tissue plasminogen to plasmin, which plasmin is just a good in metabolic products to cut the clot. It is just a good knife for the clot. But the tranexamic acid normally inhibits this conversion. It inhibits the conversion of tissue plasminogen to plasmin. So when you inhibit that one, now what will happen? There is actually buildup of clot. So it can temporarily arrest the bleeding. So this is the most common practice you will encounter in the future when you see a patient with hemorrhagic stroke. Maybe if you have time, go through to the case studies I have scanned and attached to the blackboard. In the menu, you will get case study. Then you go and through all the case studies as much as you can. Those are like the case studies we have gone through. Just selected case studies we have gone through in the previous semesters with fifth year and with fifth year students. Okay, so you need to, you can go through if you like. So this tranexamic acid is the most common practice for temporary arresting of the blood bleeding. So they are very important, but still they need to monitor because it can actually increase clot formation. So mostly they usually use for a few days. Then the next strategy, I think those are the strategies, but most importantly, BP control can be done with intravenous, short-acting antihypertensive medication like labetalol. Yes, it can be used, and nicardipine can be used to control the BP if the BP was excessively elevated. Okay, good. Then we have already mentioned about the role of surgery, like clipping or removal of the hematoma can be done, but this one will be depending on the patient condition. Yes, you know, if the bleeding is inside the brain parenchyma, we can't do surgery. The complication outweighs the benefit. So they have to try with pharmacological modalities. Then if a patient is having maybe hemorrhage due to warfarin associated, maybe we can use the antidote, vitamin K, which is antidote. Mostly should be given orally. Yeah, if it is given IV, the risk of clot formation is very high. Subcutaneously not recommended. The absorption is very erratic. Maybe even clotting factor can also be considered. Then another point to note, if a patient is having subarachnoid hemorrhage due to aneurysm, there is a probability of delayed cerebral ischemia, especially in the span of 2 weeks after bleeding. So if there is vasospasm, if this is mainly due to vasospasm of the cerebral vasculature, like if a patient is having subarachnoid hemorrhage, there is a probability of delayed ischemia due to vasospasm of the blood vessels. So this vasospasm or delayed ischemia is very common between a period of 4 to 21 days after the bleeding. So because of this reason, we do have special service used to treat this condition, nimodipine. I hope you know about nimodipine. This is the dihydropyridine calcium channel blocker. It has higher affinity. It is highly lipophilic, by the way, and it is higher affinity to dilate cerebral arteries. Because of its ability to dilate cerebral arteries, it is actually very important to prevent vasospasm of the cerebral arteries after subarachnoid hemorrhage. So this is really the most commonly used drug if the hemorrhage is subarachnoid hemorrhage. To prevent delayed ischemia, the patient is supposed to be given 60 milligrams every 4 hours for 20 days. For 21, they should be given in the form of prophylaxis to prevent vasospasm. Remember, the nifedipine and other dihydropyridine calcium channel blockers are not effective to dilate the cerebral arteries. This one is actually more lipophilic and higher affinity and higher potential to dilate the cerebral arteries. That is why in subarachnoid hemorrhage, we need to give, because delayed cerebral ischemia is very common after bleeding. Then finally, how do we assess the treatment outcome of this condition? Neurological worsening, complication, and adverse effect of the drug should be closely assessed. Those are the part of the assessment modalities. Then, how do we monitor a stroke patient? Like, for example, if a patient is taking alteplase, CT scan should be done before, of course, then before in 24 hours after alteplase infusion should be done. The BP should be monitored every 50 minutes for the first 2 hours, then after that, every 30 minutes for the remaining 6 hours, then every 1 hour for the remaining, for the next 60 hours, then maybe every other day can be considered. Then for bleeding, you need to check on the daily basis. That is very important. If a patient is actually in ICU, you have to monitor the BP, and the neurological function should be done every 2 hours. So those are the monitoring strategies for the patient who is having a stroke. Now, can we actually take us through these case studies, like for the next few minutes? Then we can end the issue of the stroke. You can see. I hope all of you are attending. We're assuming you're actively listening and attending. Then this patient is 78 years old. You can calculate the body mass index. It is a white man, actually admitted in the emergency department with a weakness on his left arm and leg and difficulty in speaking. Please note those complaints. His symptoms began approximately 2 hours ago. Compelling his wife to call the paramedics. His past medical history is significant for hypertension, dyslipidemia, and previous stroke for 2 years ago. He experienced a transient ischemic attack 1 week ago, but did not seek medical care. Social history is significant for moderate alcohol use and cigarette smoking. So the patient was having significant social history for smoking and alcohol for the past 50 years. The current medication is taking ACE inhibitor. He is actually taking statin, then aspirin and multivitamins. Okay, so what signs and symptoms does this patient have that are suggestive of a stroke, which is a very simple question. Is there any features that can suggest a stroke? Jennifer?
A difficulty.
Okay, huh? Tell us, please. No, it's people are sleeping, so we don't wait other to respond.
Weakness on the left side of his body, indicated by the left arm and leg, and the difficulty in speaking.
Okay, those are the signs and symptoms the patient is currently having. Good. Now, the patient arrives in the emergency department 3 hours after the onset of his symptom. In the emergency department, an IV line is placed and a physical and neurological examination is completed, and he is moved to the stroke unit. CT scan was done, so the patient was negative for hemorrhagic stroke and he was having ischemic stroke. His BP was, can you see, like, please note about the BP level. The patient denies any other exclusion factor, and the neurologist is actually assessing him for alteplase administration. So what is acute treatment the goal for this patient? What is the acute goals of treatment for this patient? Brian? What is the acute goals of treatment, Brian?
Hello?
Yes, yes.
Yeah, can you hear me?
Yes. What is your background noise? Brian, we are waiting. Speed up, please, because time is going. Or I have to go to another person. Then Juan? Juan, can you try? Okay, Oliver?
Yes, sir.
Okay, so what do you think?
Can we give
so what is the goal first? What is the goal of the treatment?
It is to unblock the blocked arteries.
Okay.
Resulting to the stroke.
We can block or establishing perfusion. That is the goal of treatment. Okay. So do you think yes, alteplase is a drug of choice for this patient?
No, because it's not within 3 hours. It's after 3 hours. So we can give aspirin.
We give aspirin.
Yes.
Okay. So this patient is not a candidate for alteplase. The first place, it came normally 3 hours after the onset. Secondly, his BP level was like very high. So like the risk of bleeding is very high in this condition. So the only, so he's not a candidate. So we are going to initiate aspirin for acute management. So what dose of aspirin we are going to give? 300 in our setting, but 160 up to 325 is also possible. But you know, we have to use like what is available. So I think the aspirin we're having in our setting is 75 mostly. So you just double the dose and make 150. So you just give him 4 tablets of 75 mg. Yeah, 300. Then after that, the next day you continue with what? You continue with 75, and then after that you consider to give the secondary prevention strategies. Okay, this is all what I have for today. Any other question? And this is all about stroke. This is all about stroke in brief, like in the context of practical setting. Any issues, any question or any clarification? In case if you need, you are welcome. If you don't have, you can leave the meeting, and thank you for your attention. Yeah. Make sure you start preparing the presentation because we're almost about to finalize the semester. Okay, so thank you so much. I feel like your silence is equivalent to you don't have any question. Okay.